I've worked as an obstetrician for 12 years with Toronto Scarborough Hospital. As you can probably guess, over 90% of my patients are from the Chinese community. I want to thank the Central East Lin today to allow us finally to have a frank and open discussion on the strategic refresh proposal. The first thing I want to do is ask anyone if they can read this. So while we're reading our Toronto Star every morning, up to 50% of the patients we serve in Scarborough are reading this paper. And this is where the disconnect lies. This is the Tsingtao Daily of September 3rd, 2012, again bringing attention to the tragedies that occurred at 2008 at the Birchmount site. And I'll admit, I can't read this either, but I get it translated, and that is because I want to understand what's going on in our community. After reading this and discussing with most of my patients about what happened, I realized something, that they're thinking the exact same thing as I am. Low-risk obstetrics can become high risk at any moment. They're also asking, is the hospital safe? Does it have an ICU? Does it have an efficient blood bank? Are there a lot of surgeons, nurses, anesthesia around if I run into trouble? And they're also asking, where do I go to get the best care? Oh, wait a minute. Well, hospitals evolve and patients eventually come to their own conclusions. And so I look back at last year, fiscal year 2011-12 in our hospital at the General Site campus. And as you can see, about a third of our deliveries total are Chinese women. I sorted out the Chinese woman from the rest of the group. If you take away a very large family practice, obstetrical practice at the General Site who serves mostly the Arab population, Chinese women actually account for 50% of the deliveries at the Scarborough General. This is in terms of total obstetrical deliveries. So we're a third of total obstetrical, 50% of the obstetrical. So interestingly, Scarborough Hospital is located in an area where 10% of the mother tongue is Chinese, whereas the Agincourt wards, where the Birchmount site is located, is up to 50% Chinese. So you might ask yourself, why does the referral pattern for the maternity ward look like this? In fact, we are starting to look like the Agincourt area. We draw our referrals from Agincourt. Many patients nowadays do research. They find out where the best choice is, where the biggest hospital is, and they know where to go. So we're talking about the strategic plan. And today we're talking about risks. I'd just like to show this graph. A lot of focus is on medical risks. And if we talk about medical risk, symbiosis equals safety. You have an emergency room open 24/7. You need many services. And we're all interdependent. Since I'm a gynecologist, I'm going to talk about ectopic pregnancies. If you can look at both Birchmount and General Site emergency rooms, actually over the last several years, the number of cases treated is actually about the same. So this is little miss ectopic. In the strategic refresh plan, little miss ectopic had right lower quadrant pain, so she went to the General Site emergency. The emergency doctor told her that she had an ectopic pregnancy. What? I have to wait for Dr. Tam to come to the hospital? You mean she's not in the hospital? What? There's only one operating room open with one anesthetist, and I have to wait for 7 hours while they finish a hip replacement and a gangrenous bowel from the Birchmount site? Everyone's in line? This doesn't seem like an emergency room to me. My friend had the same treatment for a ruptured ectopic at the Northwark General. Next time, I'm going to another hospital. So the next year, she had left lower quadrant pain, and she went to the Birchmount Site Hospital. I'm sure I have an ectopic pregnancy. I heard gynecologists are at the Birchmount Site Hospital. Great, my gynecologist, Dr. Wilcock, is here. Dr. Wilcock, are you going to do my surgery? What? The operating room is closed now? I have to go to another hospital? What? You're going to put me in an ambulance and make me go to another hospital to have my surgery? All right. This ambulance ride is killing me. I'm in a lot of pain. What? This is the General Site. This is exactly where I started off last year. What? I have to wait for Dr. Tam to come in to do my surgery? So, this is what we're going to be dealing with. Which brings us to the next risk, which is litigation. 1 or 2 bad cases weakens morale and reputation, and we're right back in 2008 with the Chinese community. Is it really that strategic for the Toronto Scarborough Hospital to put maternity in a place, to separate maternity? And therefore, you have a hospital where half of someone's family can't be treated. How about funding, volumes, HBAM? No community is equal. Scarborough is a new immigrant population. People are new to the system. There's a new language. They don't know where to go most of the time. Show up at the wrong hospital and you'll be shipped somewhere else. Are we going to fail them? And in the end, the community will abandon us if we don't provide adequate service. So, what should we do? An obstetrical merger at the Birchmount with 5,000 projected deliveries means that we need over $12 million renovation, just like Rouge. We need a regional center close to North York and Sunnybrook, but is that what the LIN really wants? We also need a major public relations campaign geared toward the Chinese community, which I would say will probably cost you over $100,000. We need a financial commitment for ICU, uterine embolization. We need inpatient surgery because pregnant women get sick too. And we will not provide coverage of the general site emergency room. We all know pediatric and gynecological coverage out of house is unsustainable in the long term. So, closing general site should be off the table. We have services comparable to any large-scale obstetrical unit in the city. Just ask our University of Toronto OB professors, such as Dr. Barrett. We have a level 2 closed ICU where the ICU intensivists are there 24 hours. We have an excellent interventional radiation program that is on call for us 24 hours. We have an excellent, great vascular team that will come in for us any time. So why would we dismantle a great system of safe care to save an overestimated amount of money with no proof of money savings? In the end, it comes full circle to the community. And in the end, 1,000 Chinese women per year who choose to come to the general site now will not go to the Birchmount site. And in the end, we're failing them. They will go to Markham, North York General, and Sunnybrook. So in the end, and with that said, I urge the board of this hospital, as well as the senior management team, to put down your Toronto Star tomorrow, pick up the other paper, and get it translated.
So if you're describing a consolidation at the Scarborough General site,
yes,
would you not have the same issues that they got if the emergency remains open at the Birchmount site?
We will. Absolutely. Emergency room is a major issue with any merger. I think it has to be discussed. I think in the end, you choose 2 full-service hospitals or you choose 1.
Right now, there's, I think, 18 obstetrics and gynecology people at the Scarborough site.
At the Scarborough General, there are 12.
12,
And
there are 9 at the...
I think there are 9 or 10. So overall, we're 22.
Do you cross-cover?
We don't cross-cover now.
So even after the amalgamation, do you consider yourselves one department, or is it 2 different departments?
2 different departments.
Thank you.
Good morning, ladies and gentlemen. 1 year ago, my 4-year-old niece and I passed by Scarborough General Hospital. My niece asked me, "What's the building?" I said, "It's a hospital." "What do people do in hospital?" I asked her. She replied, "They help people when they are sick." Today, a year later, I asked myself, once the budget cut is implemented, will the doctors and nurses have sufficient resources helping people when they are sick? In my opinion, the purpose of community hospital is to effectively and efficiently protect patients from illness and death. Therefore, It is unacceptable and shocking to see that the Scarborough hospitals will make deep budget cut without effectively communicating and consulting community it serves. We understand the hospital takes some measures to balance the budget, but we are more concerned of the impact and the consequence of some of these actions, especially the plan of splitting birthing and surgical services between two sites. As an expectant mother, I am afraid to give birth at Scarborough Grace Hospital honestly, because it has had multiple cases of maternal death in the past. I would rather choose other hospitals, such as North York hospitals, instead. I believe every expectant mother would prefer to give birth in a safe hospital environment where she knows the doctors and the nurses have all the resources to help her. Everyone knows that timing is everything in emergency world. It's very unsafe and unfair for the patients who need emergency treatment to transfer from one site to other site. Cutting birthing and surgical services will result in many other problems, such as crowded space, losing confidence on the hospital, complaints from patients needing more waiting time for surgery, and so on. At last, I sincerely hope you can consider the negative impact of the budget cut on doctors, nurses, and patients of Scarborough hospitals. I believe we can find better solutions to address the budget issue if we consult the community properly and listen to proposals from Scarborough residents. Thank you very much.
My name is Chen Qin, Chen Qin.
Thank you so much for being correct and serving your
Thanks. Because my English is not very good, so I just speak a little bit. Because I like to go to the journals, because there I feel very comfortable when I be there. So if we go to the Grace, because I heard my friend and then Chinese community, because it's happened a couple times, right, the stories. So that's why I like when I stay in, if we went to the Grace Hospital, it's make me feel not very comfortable. So I'm scared to go there. So that's why I hope I can still go to the General Hospital. Thank you so much.
Interestingly, I've never met those two other expectant moms, but our speech is actually almost identical. Well, anyway, my name is Yue Yue. I'm a 7 months pregnant mother-to-be. I'm registered to deliver at the Scarborough General Hospital in August. My family and I were very shocked after hearing about the strategic plan for trying to move the birthing unit from the Scarborough General and amalgamate with the Birchmount Hospital. I'm deeply worried about my baby and myself in terms of the quality of care that we will be receiving after this amalgamation. Since the beginning of my pregnancy, I've been connecting and sharing pregnancy information and knowledge with other moms or mothers-to-be on this pretty famous Chinese forum called York BBS. The forum right now has about 565,000 active members, and most of them live in the GTA area. So far, I've heard much positive feedback about the hospital, the doctors, the nurses from moms who recently delivered their babies at the Scarborough General. I also had the great pleasure to be with my friend when she had her baby at Scarborough General not too long ago, and witnessed the great care she received during this amazing moment. I was moved by the great passion and the professional skills that every single staff has demonstrated, and I knew this is where I would want to deliver my baby when it's my turn. However, some devastating news destroyed my whole plan. We were told that the birthing unit at Scarborough General might be closed and the obstetric service will be provided at the Birchmount, formerly called Scarborough Grace. Most of the moms who are supposed to deliver at Scarborough General expressed their great concern on York BBS. As most of you guys are aware, several unfortunate maternal deaths happened at the Birchmount campus within a relatively short period of time. As an outsider, it's not my job to judge who should be responsible for these losses. However, from what I found out from Public Health Agency of Canada, in the year of 2008 and 2009, there were 7.8 maternal deaths per 100,000 deliveries in Canada. Clearly, the maternal mortality rate at the Birchmount Hospital is way above this number listed by Public Health. I understand there could be many different reasons to explain that. However, we would not wish to risk our own lives to prove that Birchmount is a great hospital and simply believe that these people died because they just had bad luck. Our other concerns we rose up on the forum were like, will the Birchmount Hospital be able to accommodate all of the OBs and their patients? Will the number of nursing staff double if the patient population doubles? If not, will the quality of care change due to lack of staff and overwhelming patients? Will the waiting time be even longer? Will there be an anesthesiologist on call 24/7 to give us epidural 2 a.m. in the morning? Will there be a pediatrician in-house 24/7 if the newborn babies run into trouble? Will there be an operating crew and a surgeon available 24/7 if the moms need emergency surgeries that's beyond the scope of an OB? Will there be an ICU available 24/7 in case if the moms need critical care? Will the blood bank be open 24/7 if some moms need urgent blood transfusion? All of these questions need to be answered before we make an informed choice of whether we should stick with the Scarborough Hospital or look for other alternatives. In conclusion, as of right now, Scarborough General is still my first choice to deliver my baby. I respect the organization, trust the staff, love the environment, and believe in their unbeatable service. However, in worst case, when the amalgamation is inevitable, I would like to be informed as soon as possible so that I can be transferred to a totally different hospital that I trust. Examples are Northstroke General Hospital or Markham Stouffville Hospital. Thank you, that's all.
Good morning. Thank you for allowing me the opportunity to present to all of you. So I'm going to be talking about the role of interventional radiology in obstetrics and gynecology and the maternal newborn program. Just to give you some background, I've been an interventional radiologist and I've been working at the Scarborough Hospital General Site for over 10 years, and my practice is focused on doing endovascular procedures. So just to give you an outline, I'm going to focus on uterine artery embolization, specifically more to postpartum hemorrhage, the treatment of uterine fibroids, adenomyosis, gynecologic malignancy, uterine AVM. I'm not going to touch on abscess management or maternal hydronephrosis, but these are some of the areas where we are very involved and provide a lot of treatments for the patients related to the program. So looking at postpartum hemorrhage, it's a major cause of maternal morbidity and mortality. It occurs in 2 to 10% of deliveries. Life-threatening postpartum hemorrhage occurs in 1 out of 1,000 deliveries, and this has been well documented in peer-reviewed literature over 50 years. In the Scarborough Hospital, the Central East Lind, there's a proposal to create a high-volume delivery site with 5,000 deliveries per year. This would equate to 5 life-threatening postpartum hemorrhages based on the literature to date. So postpartum hemorrhage, the management starts with conservative measures, management of hemodynamic shock, urotonic drugs, vaginal packing, surgical repair of superficial tears. But what happens when these measures fail? And this does occur and has occurred multiple times, and I'll go over some of our history. So after failed conservative measures, you go on to vascular ligations, hysterectomy, uterine artery embolization. The operative options are limited, have considerable risk in hemodynamically unstable patients. Endovascular arterial embolization is the standard of care for refractory postpartum hemorrhage at a high-volume delivery site. This is accepted across North America, in the United States, and in Canada. So endovascular arterial embolization. There's been a long history of proven success in trauma for splenic trauma and pelvic fractures. There's over a 40-year proven history in the literature for pelvic hemorrhage, for life-threatening pelvic trauma, cancer-related bleeding, obstetrical hemorrhage, and postoperative hemorrhage. And I've given you the references there to date back. So looking at the results of arterial embolization in postpartum hemorrhage, I provided you with a summary, which I won't go into the details, but you can see that the initial control of bleeding is ranging anywhere from 80 to 100%. Some of the studies are earlier where we didn't have some of the newer technologies with catheters and some of the materials we use. So I would say at this stage we're very close to 95 to 100% success rate for control of bleeding. So what is required for a pelvic arterial embolization program? You need specialized, skilled, dedicated interventional radiologist. You need an appropriate supporting team comprised of trained interventional radiology technologists and nurses. You need supporting medical services and an integrated team approach, including high-level ICU care and integration with the obstetricians and gynecologists. This is a team approach. It's not one individual. It's not one person. So where is pelvic arterial embolization available? Within the Central East Lynn in Scarborough, there's only one site. It's at the Scarborough Hospital at the general site. We have experienced dedicated interventional radiologists that have been doing it for over 20 years. We have experienced skilled interventional technologists and nurses who are dedicated to the practice of interventional radiology. We have tertiary level ICU, and we have the medical support services. Can these skills be imported from site to site? No. And the reason for that, there's different radiology business groups with different clinical and business agendas, and this has been dealt with for the last 50 years and has not changed. So what is our experience? From January 1st, 2011 to May 1st, 2013, at the Scarborough Hospital General Site, we performed 6 emergent pelvic arterial embolizations. I can provide the specific patient names if there's any question to this. These cases have been done for postpartum hemorrhage, for post-C-section uterine AVM, for dysfunctional uterine bleeding, for uterine fibroids, adenomyosis, and for gynecologic malignancy. To also provide you some background, we performed over 62 elective uterine artery embolizations for patients with symptomatic uterine fibroids and adenomyosis. We have one of the largest uterine artery embolization programs in all of Canada. So to conclude, to create a high-volume maternal newborn program with 5,000 deliveries per year, that equates to 5 lives at risk per year secondary to refractory postpartum hemorrhage. This is based on the literature. Without a pelvic arterial embolization program, is it possible to transfer hemodynamically unstable patients to academic centers and other sites? I would think not. That's why you have dedicated trauma centers for bleeding, because these patients cannot be transferred. We currently have the skills and required personnel within our LIN, within the Scarborough Hospital, at the Scarborough Hospital General Site. So I ask the question to you, is it necessary to place the lives of newborn mothers at risk? So that's my presentation.
Thank you very much. Questions from the panel? Yes.
What's your time frame for mobilizing your team? I'm taking the interventional radiologists aren't in-house, nor is the support staff.
Right, we're not in-house, but we actually have a system for these kind of catastrophic cases, either from ICU or for the postpartum hemorrhage. And usually we can be in anywhere from 20 minutes to 45 minutes, right? But usually the case is, unless it's coming from the Birchmount site, where whatever that transfer time is, but basically once the patient gets into our hospital, we are dealing with it anywhere from 30 minutes to 45 minutes.
And there's a follow-up question. Resuscitating an unstable, hemodynamically unstable patient in a radiology suite is challenging.
Yes, and we've had a lot of experience with this, not just in this setting, but just with ICU. We do a lot of procedures because our ICU has a lot of complicated patients, and we have been very comfortable, given our room capacity, the way it's set up, to do those, and we've always been set up and prepared whenever we have these cases with appropriate things outside the room in case the patient does crash. And obviously we have the ICU monitors and everything, which are brought down, and those are all started up instead of our usual interventional radiology monitoring system. Yeah, so we always have an ICU supporting medical staff, and 2 nurses usually come down to in this kind of a situation.
So you are providing this service to the Birchmount site now?
Yes, we are providing to the Birchmount.
Patients that you described transferred from Birchmount?
Yes, patients are transferred from the Birchmount if we're called. If we're not called, then you obviously you don't have the opportunity.
But my point is,
Yes.
that what about these cases here? How many of those were from the Birchmount?
Of the 6, I can't give you an exact number. I know from the 6, I did myself 3, and out of those, 1 was definitely from the Birchmount. I know that for sure.
I was wondering if you could elaborate on the slide where you said that this program could not be something about the business.
Yes.
I wonder if you could elaborate just a little bit more. Is this a physician level reason that things couldn't be moved? Is there other resources?
Well, I think there's it's a 2 or 3-fold thing. Touching on the physicians, there's basically different radiology business groups. There's one radiology business group which covers the Centenary site and the Birchmount site, and a separate business radiology group that covers the Scarborough General site. There's no integration, and I do not foresee that. This has been going on for 50 years, so that's not going to change. So there's no potential for myself for even to go into the Birchmount site. I once tried to do a procedure, and I was threatened with legal action if I stepped on foot by the other radiologist on the other side. So I would not be allowed. So even if I wanted to go and help, which I've tried on multiple occasions, I'm not really permitted because I don't really want to get sued, right? As for the team, I think you need to have a really good team of the interventional technologists and nurses who are comfortable with this kind of a situation because it is very stressful. You have to make very fast judgments, and you need to have that. I think that you can train people to do that, but you need to have adequate volume, and they need to be doing these procedures on a daily basis to have that comfort level to take this kind of a catastrophic situation.
Can I ask a question?
Sure.
Are all intervention procedures performed only at the Toronto General after hours, the Scarborough General after hours, or is it, do you have cross coverage at both sites, and if they're needed at the Birchmount site, you have to go in to take care of the issues that are happening?
So basically, for non-vascular issues, I'm not sure what happens, right? Because that we're not involved in. I can say for anything endovascular, arterial, or venous, basically those patients get transferred over to the general site from the Birchmount. I'm not sure what's happening at the Centenary site. I can't speak to that. But I know at the Birchmount site, there is a mechanism where the patients get transferred over. There's a most responsible physician who takes a responsibility at that point, and then we do the procedure. Is that answering your question?
Essentially,
Yes.
you don't do a large number of intervention procedures at Birchmount,
There's no vascular procedures done there, no.
or vascular procedures?
Yes.
Sure.
Yes.
Just to clarify, do you have medical privileges across both sites?
No, I do not think I have medical privileges at the Birchmount site, no.
How many of you are there? How many interventionalists are there?
We have 3 dedicated interventional radiologists, and we are basically all of us are regularly rotating through the rotation.
So you offer at the general site 24-hour service, 7 days a week,
Tw-
52 weeks out of the year?
Exactly, 24/7, 52 weeks.
Thank you very much.
Good morning, ladies and gentlemen. My name is Jocelyn. I have worked at Scarborough Grace Hospital for almost 24 years, back when it was known as the Salvation Army Scarborough Grace Hospital, and then was subsequently merged with the Scarborough General Hospital. I've actually worked at both sites. In fact, I'm also familiar with the Centenary Hospital, where I worked in the psychiatric unit during my training and returned later to work there for the NICU course. I feel that I have an obligation to share my concern with you. I completely agree with the doctor just said. I believe that Grace should be the ideal place for the combined unit. Furthermore, there should not only be a simple move of medical staff from the general site to the Grace, but I think we should make the Birchmount campus solely for the maternal hospital. In the same way the Sick Children Hospital is solely for children, the Princess Margaret Hospital specializes in oncology. We need a maternal hospital for mothers and babies. The following are the reasons why. Number 1, Grace Hospital is a historical landmark within the Scarborough community. With Markham, North York, Unionville nearby, it is the culmination of many people's hope, dreams, and expectations. Many people donate generously to build Grace because they felt a hospital was needed in this particular community. World-renowned and remarkable Canadian pianist Glenn Gould, who was one of the generous givers, donated $4 million for building Grace before he died. And a portion of the sale of each CD contributed to the hospital, according to his best friend, Lon Talk, who did the recording of the music CD for Glenn Gould. That is why the library in the Grace Hospital was once called the Glenn Gould Library, when Grace was formerly the Salvation Army Hospital. During that time, I could still find some books in the library with the stamp Glenn Gould Library on them. When Glenn Gould died, even the Americans sent a Pope into space containing his music to remember this talented Canadian musician from Toronto. Number 2, Grace is situated within reach of Toronto, Markham, Unionville, and Scarborough. Grace can be reached easily by traffic coming from several major highways, 401 East and West, 407, 404, Don Valley. Number 3, Grace is in a cultural diverse area with residents of various statuses, immigrants and citizens. The Chinese, the Blacks, Indian, Sri Lankans, Acadians, and other Asians live within the community. Number 4, Grace's physical structure and size are appropriate for the conversion of a single maternal hospital. On the other hand, the general campus and the Centenary Hospital are both too big and complex to be converted. Number 5, Grace already has many experienced and multilingual obstetricians, OBS nurses, and midwives, pediatricians, and technicians. With the transfer of the experienced staff and nurses from the general campus and the Centenary, it will become a unique hospital specialized for mothers and babies and GYN patients. Number 6, we can turn the emergency department into a maternity triage for labor assessment, antepartum assessment, threatened abortion, postpartum follow-up, and other situations. Number 7, we can enlarge the NICU to care for all levels of neonatal patients, including the premature newborn infants. Number 8, day surgery is ideal for DNC and the other gynae cases and early pregnancy assessments. Number 9, OBS doctors and midwives will find it more convenient to have their offices within the hospital so that they can care for their patients in one area. Rather than renting the office elsewhere, the rental payment will also help the hospital finances. Number 10, we can have all the units in one place. This would include the infertility clinics, the NST clinic, the antenatal class, the breastfeeding class and clinics, postpartum follow-up and checkup clinics, pediatric and newborn follow-up clinic, and postpartum mental health care unit. Number 11, midwives will also most benefit from all the backups, assistance, consultations provided by the OBS specialist and pediatrician in case of any unmanageable situations, particulars for the patient's safety and benefit. On the other hand, midwives will be good assistants to the obstetrician in many ways. Number 12, Grace will be a unique place, especially a common day for midwifery training of student obstetrician and student midwives. Grace will attract more OBS and maternal experts to join the profession because of its specialty programs. Number 13, pregnant women and their family will know exactly where to go for help when there's a problem. Number 14, there can be a store for all the needs and conveniences for mothers and their babies within Grace, such as breast pump rental, breastfeeding accessories, breastfeeding support pillows, diapers, and more. The revenue generated will also profit the hospital finances. Number 15, it will eliminate much confusion for the location department when they're sending messages. Because there was one case, the message was sending wrong hospital with one locating department. In case of obstetrical alert, every staff is trained for these particular situations. 16, most of all, Grace has a perfect and ideal labor and delivery 4-year unit in place already as a model. Originally designed and built for labor and delivery with all the facility to care for newborn emergencies and C-section patients. Within the labor rooms at Grace, the structure was designed to provide every need for nurses and patients. All equipment was accessible with the premises in shelves and drawers in the room when needed, rather than carted in from far-off storage room. Oh, sorry. In contrast, the family maternity center at the general campus was unnecessarily large birthing rooms which isolate nurses and patients from the rest of the staff in case of emergency situation, with the nurses station located at one end of the hallway and the other birthing room at the others. Communication is delayed between staff members in order to deal with the emergency. Grace is like the soul of the community. The maternal newborn is the heart of the hospital. While it may not be evident now, there is the potential for it to become a great mother and babies hospital in Toronto. As you may already be aware, there have been some slandering by staff from one of the other branches against Grace Hospital ever since the tentative decision has been made, for what I could only assume is an attempt to disqualify Grace as the viable choice. Let us not allow this kind of unprofessionalism to cloud our judgment or taint the decision-making. We are related branches of one family. One day, staff of all 3 hospitals may end up working together at Grace for a greater future. Do I still have time? Okay, my hope is that what envisioned above will not be the distant future, but rather that the time is now to plan and build the unique and much needed facility. Thank you for sharing my dream. My job is an RN, obstetrical nurse. Yeah, you're welcome.
My name is Rai Reece. I'm a college professor as well as a women's health researcher at Humber College. So today I want to, first of all, thank you for allowing me to speak and present before you. I want to discuss my experience as both a patient in 2008 and 2013 for the birth of my beautiful daughters at the Toronto Scarborough Hospital. I also would like to discuss the broader socio-political implications that the potential closing of this maternity ward has for women in the community who access the hospital regularly. In addition, I believe this discussion has very broad implications for a more nuanced discussion regarding women's healthcare and access to services that have a direct effect on pre- and postnatal care. So I want to begin by talking about my personal experience. In 2008, I had my first daughter. I had a very routine pregnancy. I went into the Scarborough Hospital when I was in labor, and my daughter developed tachycardia. And so I had a very skilled physician, Dr. Georgina Wilcox, who made a split-second decision, which allowed for me to have an emergency section, and what I believe actually saved the life of my daughter because she had a severe tachycardia. The quality of care that I received at the Toronto Scarborough Hospital during that time was unparalleled. I was very, very scared during the procedure, and afterwards, I was scared for my own health as well as that of my first daughter. In 2013, I had this lovely little girl here, and she's 3 months yesterday. And at the time of my pregnancy with her, it was a routine pregnancy, but I myself was diagnosed with a heart condition during the second week of my pregnancy with this little one. I had an elective C-section because I had an emergency C-section with my first daughter. Again, I was at Scarborough Hospital under the care of Dr. Georgina Wilcox and her team. At this time, the elective C-section, having now been moved to the same floor as the maternity ward, I found made the transparency very seamless in terms of my quality of care. The knowledge of the nursing staff, the fetal monitoring I received, the very detailed, oriented care I got from the physicians on staff was unparalleled. And I do believe that the hospital visits that many women have to make prior to the birth of this little girl, I had to get fetal monitoring on a regular basis, and the close proximity to the hospital made access to care for myself and my baby efficient. The second thing I'd like to talk about is the broader socio-political implications that the potential closing of the Toronto Scarborough Hospital may have for women. I'm going to break it down into two separate levels. The first level is the macro level, or what I term the macro level. I believe that the streamlining of healthcare services, particularly access to care for pregnant women, can be seen in a larger context of a more nuanced discussion involving cuts to social services that directly affect and have an impact on women's health. First of all, with the potential closing of the maternity ward at the Toronto Scarborough Hospital, we are potentially looking at a saturating of an already overstretched healthcare system. This could potentially result in lesser quality of care due to an increase in the number of women requiring service at another hospital. This is not to negate that the other hospital could be capable or the ability of the staff. We're talking about sheer volumes and the number equipped to accommodate the volume of women who are now going to be requiring pre- and postnatal care. So what does this mean for the care of women and their babies? There are also implications evident for the number of women, men and women who may potentially lose their jobs at the Toronto Scarborough Hospital if the maternity ward is closed. In terms of the macro level, the centrality of the location of the Toronto Scarborough Hospital is critical to the care and access that it provides for women. I am fortunate that I am able to drive to my appointments. However, Scarborough is a city that is thriving and populated by many working class families. So if we're looking at the socio-political economic provisions that the closing of the hospital may have, many of these families, particularly women who have other children, rely on public transit to access the hospital. The location of the hospital makes it easily accessible by transit in a way that reduces travel time for women getting to their many appointments, particularly women, as we know, who are in many cases the primary caregivers for not only their children but other family members. In conclusion, I respectfully urge the review panel to carefully probe and examine the implications for women's health care if the closing of the Toronto Scarborough Hospital takes place. As mentioned, some of the salient issues, including but not limited to access for care for women, the quality of care, staff employment, these are all subject areas that we should be concerned about, not only as individuals, but as a community. Having a baby is a momentous event. It's one filled with joy and in some cases fear. I received excellent care at the Toronto Scarborough Hospital for both of my pregnancies, and I don't believe that I am an anomaly. I believe I received such great care because of the commitment, dedication, and high standard quality of care practiced in the maternity ward. I appreciate your time and your consideration. Thank you.
Thank you for your presentation.
Oh, okay.
Questions from the panel? I like the framing of macro and micro point of view because I think it's legitimate. But the thing is I just want to make sure that I understand what you're proposing clearly. Because in arguing that if you move one service to one site, you're overloading it from a macro point of view, I understand that. But that applies if you're moving in the other direction. So you arguing that both sites should be kept open?
Absolutely. Yes, sir.
Thank you very much.
Thank you.
Good morning, ladies and gentlemen. I'm Mei Yun. I came to Canada from Hong Kong in 1974 and lived in Scarborough for 34 years. My parents, who recently passed away, were Scarborough residents too. Since the opening of the Scarborough Grace Hospital, we feel safe and benefited from it because Scarborough Grace Hospital is nearby and can be easily reached by TTC, especially for people who do not drive. My parents were both seen by the emergency department of the Scarborough Grace Hospital and were treated and cared as the inpatients for few times. They survived from strokes and other problems and have lived healthily for some terms before they passed away. We were happy with the hospital care. I'm glad that Scarborough Grace Hospital is nearby and available for us. Thanks.
Everyone. My name is Helen Liang. I came from China more than 10 years ago. I had 2 children. They were both born in Scarborough Grace Hospital. It is hospital near my house. My daughter was born in 2003. I just got a baby boy last year. I like Grace Hospital very much because when I have a problem, I can go to Grace. 1 week ago, I had CT scan in the Grace Hospital. I am going to see the doctor soon for my nose. We need the Grace Hospital. Thank you very much.
My name is Beth Gomolka. I'm a staff pediatrician at Scarborough General. I also work part-time at Sick Kids. I'm a hospital-based pediatrician in both places, doing hospital shifts at Scarborough and at the general site, and I work on the inpatient unit and in the emergency room at Sick Kids. So I just want to tell you a little bit about what I tell people when they ask me what's it like to work in Scarborough. And I say, well, when I'm on call, I may see 8 to 10 newborns in a 24-hour period, and you walk into every room, I see a family speaking a different language from a different country, and each and every one is having their firstborn child in Canada. And I think that really helps illustrate the type of community that we serve. So I wanted to talk a little bit about the unique needs of this community, who serves them, how we provide care from a pediatric point of view, what we know about what young families want and need from healthcare providers in the Scarborough area, in southern Scarborough at least, and what we don't know about the community in terms of their needs and wants. So I'm sure you've heard it here before, and you might hear it many more times over the rest of the day. There are very specific socioeconomic factors that help direct the needs of the Scarborough population. This impacts access. There are a lot of newcomers to Canada. There's a higher proportion of recent immigrants in Scarborough than in other parts of Toronto and certainly other parts of Ontario. And some of them may not have knowledge of our healthcare system and then definitely need help navigating that. So we know that we have a higher disadvantaged community. They have extreme financial hardship. There may be family disruption. They may not have social supports being newer to Canada. They may not have their entire extended family here. Some are immigrants, some are refugees. They may have limited social supports. We know that child poverty and single-parent families are closely intertwined, and we see higher rates of both in many wards in Scarborough. And certainly, we have a very high proportion of those that live in deep poverty. And that certainly impacts on their healthcare needs and how they access healthcare. So in the Eastern GTA, we know that there are more city wards with greater than 50% single-parent low-income families, and that is certainly concentrated south of the 401 between the DVP and Morningside, and we are smack in the middle of that at the general site. And many are likely to access the hospital via public transit. I should mention that there was a survey done by the hospital that showed that 85% of patients access the hospital by car, but the median age of those that answered that survey, the median age was 50, and I would propose that the young families may not be accessing by car, and many will be more likely to use public transit. We don't know what the number is, but I'm going to suggest that. This is from the report card on children from the City of Toronto. It's found on their website. It's just one of many maps that you can see there that shows the concentration of, I'm sorry, I can't point. The pointer's not working. It shows the concentration in the light orange and dark orange of higher proportion of wards of children who are living in deep poverty. That's where over 30% or over 32% of people in that area are below the poverty line. And certainly I think we need to make sure that we address their needs in a very unique way. So what are our unique solutions? We certainly have identified the fact that not everybody has access to a primary caregiver in a timely fashion. They may not know how to navigate. They may not know where those primary caregivers are. There may or may not be a shortage of family doctors in Scarborough, but we have found many families that just will come, will have their baby. We have a postpartum clinic where we see every baby who's discharged. And when I say, well, your baby needs to be seen by your family doctor within 1 week, who is your family doctor? Many will ask me if I can be their doctor. They'll name their obstetrician, or they'll say, well, we know we have to find one. And there has been no planning, and they really need a lot of help navigating that. And so we do a lot of matchmaking. We have a pediatric day clinic that runs 7 days a week from basically morning until early evening. And we can book children in clinic who have been seen in the emergency room the day or two before that need follow-up, so the emergency physician has the peace of mind that the patient that they're discharging will be assessed again. And certainly when I work in the emergency room at Sick Kids, it's a big black box. We send kids home, we tell them to go to their family doctor, and I'm in good faith hoping that they have one that they can access. So I think the patients in Scarborough, the children, are actually well served by this. We also can get direct referrals from family doctors of children who need to be seen acutely, and so those children actually avoid their initial emergency room visit. They come right up to our clinic rather than just being sent to the emergency room to be cared for from the family doctor's office. Our PEDLink clinic is in a way a fast track from the emergency room for children that need to be observed for a certain amount of time, but what we try to do is get them out of the emergency room and bring them out to the pediatric floor where our PEDLink clinic runs out of, and it's a much more child-friendly environment. And I think we avoid admissions. We also avoid excessive lengths of stay in the emergency room, and I think it offloads from the emergency room. We also are able to see discharged inpatients who might need follow-up, a newborn baby who's discharged for jaundice, who needs a repeat bilirubin. Yes, we could send them to their family doctor, but I don't think we're making that follow-up necessarily easier. As you know, a bilirubin, if it's done in a family doctor's office, the result may come back late that night or the next day in some cases. So we have a fast turnaround time. We can check children who've been discharged from even more serious illnesses to ensure that they are fully recuperated. And then we send them back to their primary physicians. So who serves the children in Scarborough? We know that there are many family health teams, there are many primary care providers, and they do the bulk of work to provide primary care for healthy children in Scarborough. There are many children that are seen in walk-in clinics for primary care. I don't think that's ideal. No one does. That is a reality, and certainly that's one of the reasons why we ensure that we have a lot of strong pediatric follow-up, because we're not really sure where parents will choose to take their families or where they're able to take their families thereafter. Just in terms of the acuity of children that we see in the emergency department, in 2012, this is provincial data that shows that 18% of pediatric visits for both sites, Scarborough General Site and Birchmount Site, we saw 18% of our children were C-test 1 or 2, and I just have comparisons for other hospitals in the region. So what do young families want? We know that we did focus groups at the end of 2012 in an attempt to get feedback for our new service delivery model for maternal and newborn care. We know that mothers who were interviewed want culturally sensitive care. They want help navigating the healthcare system, both during their pregnancy, delivery, and throughout the continuum of care for their child. They want language support. They love the postpartum care that we provide. And they want access to pediatric specialists when needed. Well, what do we not know about the needs of the community? I think we need a lot more community engagement, probably by focus groups. I think that surveys, it's hard to access. This is a bit of an untapped community. It's very hard to access them for information in terms of really finding out what they need. They're busy, integrating into Canada and trying to make ends meet, and I don't know if we're getting the information directly from them. The focus groups that we did, I think, were just the tip of the iceberg. I think we really can tap into that, and I think that should be spearheaded by the LIN to really know if we're on the right track. And there's a concerted effort that we need to reach in order to reach that vulnerable population, in order to really get their input. So the consolidation plans that were passed by the board in March didn't really take into account the needs of the community, because I don't think that we've had adequate engagement or consultation with them, this community that I've talked about. And I think that needs to happen in order to really ensure that the decisions we make will provide for them in the future. Thank you.
Thank you very much for your presentation. Questions from the panel?
I'm just wondering if the same services are repeated at the Grace campus, would that make a difference?
So if they were, or are they?
If they are.
If they are currently. So the answer is yes and no. They, as a rule, not every baby discharged from Birchmount campus is seen in the postpartum clinic. There is an ability to follow up those that are identified that need follow-up. There is a pediatric day clinic, and it functions pretty much the same way. And the pediatric link clinic was initiated about maybe 18 months to 2 years ago. We started it first at the general, but it does exist there as well. The issue, though, is whether or not the needs of the community around the general site who are accessing it by public transit, whether or not they will get to Birchmount site. That's a different question.
Two questions for you. The first, to focus on the inpatient side, I'm wondering if you could speak from the pediatric perspective of any downsides or major upsides that you see to consolidation, irrespective of the sites.
I think in order for the pediatric inpatient care to function safely and well, it would have to be integrated in the same place where you have an emergency department and a busy family maternity unit and NICU. That's the best way I can answer your question. What I would not feel is safe is if you had a freestanding pediatric unit without family maternity, without NICU, and perhaps with an emergency room that may not become as busy, because what happens is families have their babies in a hospital and they tend to feel that that is their hospital. They will come back there if they need care again to an emergency room.
And the second part is to focus more on the outpatient side. This is a bit of a broad question, but given your experience, what do you see in an ideal world, the needs for pediatric outpatient care? So in an ideal world, you create that. What are the needs that you see?
I think, I think what we're addressing the acute care needs of children very well right now, the way it's set up. I think we do have some subspecialty clinics that one of my colleagues will talk a little bit about. We have a few areas where we don't have a subspecialist, for instance, pediatric GI, where we don't have someone on site, but we refer, and we have actually very good relationships with Rouge Valley, and they do have some of those pediatric endocrinology would be another example. And ideally it would be like everything in one place, one-stop shopping, sure, but I think that if you have good links with other centers, it works as well.
Question for you. I take my child to Scarborough General Hospital. They're seen there and need to be followed up at the Link Clinic, but I live closer to the Birchmount site. Is there something in place at this stage of the game that person will be followed up at the Birchmount site, or do they have to come to the Link Clinic that you actually have at Scarborough?
So PedLink is actually for it's children who are currently in the emergency room that it can't be discharged. But I think the pediatric day clinic would be what you're referring to, where someone is ready to go home, but the emerge doc really says, oh, this child really should be seen again. Many of the emerge docs will work in both places, and it's one more step for them to pick up the phone and call the Birchmount site to make the referral there. For a person like you who speaks English, who can advocate for himself, it would not be a problem. For those who may not have those abilities or strengths, I think that they wouldn't necessarily speak up or be able to communicate what they want, and they would come to the appointment that they were given. So.
Any further questions? I have two. First of all, how many pediatricians are you assigned?
It depends if you count full-time or part-time, but you mean how many pediatricians are on the call schedule? Roughly between 6 and 8 any given month at each site.
Each site. And all of you have privileges of both?
We should. Most do. I would say the majority do. Yeah.
So if you cross cover, do you ever go over?
I have. I've had when there's been a need, and certainly we've had our colleagues from Birchmount come when if we've had a colleague who's been sick or some personal issue. We work very well together. We, as the pediatrician, the department is one department, and I'd say we function two separate sites, but we come together for policies. We support each other as best we can when the need arises.
Thank you.
You're welcome.
My name is Leah Tattum. I'm also a staff pediatrician at the Scarborough Hospital. In addition to doing hospitalist work, I also work a pediatric consulting clinic in an office that is close to the general site. My role today is to talk to you about what we currently offer in pediatrics at both the Birchmount and the general site. Okay, so I just forward like this. Great. Okay, the first thing that we do is we offer 24-hour in-house pediatric service at both the Scarborough General and the Birchmount site. To emphasize, this is not offered at all GTA hospitals. Lots do have similar services, but a lot of hospitals will have pediatricians that do home call. In addition, we do not get a stipend from our hospital global budget to be on call. And this cannot be said of the Rouge Valley system, which is the other major hospital in the Scarborough area. Their hospital global budget stipends to their pediatricians cost them approximately $250,000 a year. Dr. Gamalka touched on it briefly, what we do in the hospital, but I thought I would highlight it because we have lots of unique services. The first thing that we do, which is provide service to labor and delivery, at both the Birchmount and the general site. And to put in perspective, the general site has approximately 3,000 deliveries a year, which is the most number of deliveries in the Central East Lynn. We're also accessible rapidly to the NICU, which on both sites is a level 2B, easily converted to a 2C level, which takes care of slightly younger and slightly more sick babies than a 2B. Oops. We have the post, there we go. We have, oops, how do I back up here? Can you back me up? Nope.
You just go a little slower.
Okay, we have our postpartum clinic, which is a unique service, and it is offered at both the Birchmount and the general site. Every baby that's born in our hospital is brought back to our postpartum clinic 2 to 3 days after discharge. This is a universal service offered to every baby 7 days a week, 365 days a year. Even the family doctors that deliver in our hospital utilize this service. As Dr. Gamalka touched on, our population are offering newcomers to Canada, people whose English is often quite a second language, and people who are not used to accessing healthcare in Canada. This gives us an opportunity to see a baby in the first week of life when they are at their most vulnerable. We are able to diagnose all sorts of congenital diseases before they become critical. Specifically, we've identified congenital heart disease. We see jaundice. We're able to identify jaundice, admit patients from our clinic. They don't need to go to the emergency department. We offer breastfeeding support through our nurses and also a partnership with public health. And we can offer lots of social supports to the families in the clinic. We have our pediatric day clinic. This is a service that takes referrals from the emergency department, directly from family doctors, patients who we've discharged, patients who need pediatric specialty follow-up, and it often can avoid a return or even an initial visit to an emergency department. This service is also offered 7 days a week, 9 a.m. to 8 p.m., and it provides extreme flexibility for families. I'll give you an example of a teenager I saw yesterday with a large left lymphadenitis who's heading into exam time. And I said to him, listen, I'll send you home, but you need to come back tomorrow to clinic to see the doctor on call. And he looked at me like, I'm not coming because I got to go to school. And I said, fine, what time does school end? 4. I'm like, great, come at 4:30. And he, like, shock, right? Oh, okay, sure. And hopefully he came. You know, we can lead them to water. So this will also facilitate early discharge because we know that our patients have follow-up. We know that we can rely that they will come back to our hospital, that they will see one of our colleagues on call. And this does not replace family doctor follow-up. This is not something that we will have for the long term. This is something that will help us bridge the first few days or few weeks of somebody who is in an acute illness. Our PEDLINK program is unique, certainly to the GTA, and may even be unique to the province. This is a program where emergency room doctors can make a direct referral to the pediatrician from the emergency department. The child can be taken out of the emergency department and assessed by the pediatrician in the pediatric department. And at both sites, I believe it's on our pediatric ward. This is a pediatric-friendly environment. The staff is geared for children. The teaching is aimed at children, and we have child life specialists on weekdays that can help ease some of their emotional discomfort. This improves the experience for the children and for the family, and it can also move children out of the emergency department and improve wait times in the emergency room department. Some examples is a child who comes in with some nausea and vomiting. We're able to get them out of the emergency department quickly. We can offer them fluid trials. And if they fail that, we can give them IV fluids. We can observe them for several hours on our pediatric ward and make a decision later whether or not they need to be admitted, or if they can be sent home and brought back the next day to the pediatric day clinic for further assessment. We also, of course, do emergency consultations where there's in-house availability to rapidly consult to the emergency department 24 hours a day, 7 days a week, 365 days a year. We're able to manage the sickest children in the emergency department, which not only gives better care for children, but also can free up some of the emergency room physicians to deal with other patients who may not be within our age group. Finally, I'd like to talk about our most important outpatient clinics that we provide at the Scarborough Hospital. Now these are at the general site. We have a neonatal follow-up program which has been functioning for well over 10 years. This is for children who were born at both sites who meet certain criteria that need ongoing follow-up. We have a neurologist, we have experienced pediatric OT, and we have speech pathologists that run this program. The children are seen on a regular basis, at least for the first 18 months of life. We also have 2 very experienced pediatric occupational therapists who have their own clinic that can accept referrals from pediatricians that are affiliated with our hospital for assessments of children that we see in our office. And the last clinic I want to talk about is our developmental clinic. This is a developmental clinic that's been functioning for over 30 years with no separate funding from any other services. It's the only program in Scarborough that offers services to over 600,000 people. This is in knowing that up to 17% of children will have some type of developmental or behavior problem, and now 1 in 88 kids are being diagnosed on the autism spectrum. Grandview, which is a program that sees children with developmental delay, will not see patients from Scarborough. And Bloorview, which is the main site for children with developmental issues in our area, only began seeing children from our part of the city last year. And that's only at their main site, which is at Eglinton and Bayview. Those satellite clinics that they have throughout the city will not see patients from Scarborough. So this developmental clinic is really the only option for most of the children in Scarborough. And that's it. Questions?
Thank you very much for your presentation. Questions from the panel?
So, first off, I applaud the group for coverage for all of it right now. It seems very robust. In the event of a consolidation or merger of the inpatient services, how would you see the group evolving, both to cover the inpatient side, which I imagine you find quite busy, but then also the secondary side, where there's been a direction to say that pediatric coverage will be provided to that emergency department?
I think as a group, this was not a plan that we support. We certainly, as pediatricians, work well together. Like Dr. Gomalka was saying, we come together very nicely for policy. And I think if we consolidate onto one site, we could work well together. I think our issue is the site that does not have maternal newborn and NICU support and has a pediatric coverage without that. That we feel would be an unsafe situation and would be difficult for us to cover.
Just a follow-up to that, were there discussions or could you elaborate further on possible solutions to that for that site?
Well, I think the site that does not have maternal newborn support would have to not offer pediatric support and would have to announce very clearly to the community in whatever ways they deem fit that children should not come to this emergency department because it would not be safe for them.
I just have one question of clarification.
Sure.
You were talking about the newborn postpartum
Yes.
clinic,
Mm-hmm.
and said that every baby was seen in that clinic.
Yeah.
or to be seen in that clinic. I know that midwives will see their clients three times in the first week in their homes. Are those clients also being seen in your clinic?
I'm not. I primarily work at the general site, and I have not experienced very many midwife deliveries. I think, no one has to come to our postpartum clinic, and that would be a decision that would need to be made between the midwives and the pediatricians.
Any other questions? clarification from the information that we've received at Scarborough General Site, the inpatient average utilization of the beds is around 50%, and it's about the same for the Birchmount site. Is that your understanding?
That is my understanding. Our chief, Dr. Peter Azzopardi, will be